To think outside the box, you must get outside the box. There are many barriers to innovation, especially tradition, committees, groupthink, and conformity. They all want you to know what we know for sure. There are other barriers to innovation. Educational programming of our mindset. Our formal education, we have to repeat what we know for sure. In exams, we repeat what we know for sure. In residency, we repeat what we know for sure. Fellowships, more of the same. Board exams, more of the same. And clinical practice guidelines. What we know for sure may not be true. The government has many barriers to innovation. The cost of time and money to get regulations approved. After that, to have commercial viability, you have to have reimbursement codes. Arthroscopy has provided a power for innovation. So what about us? Are we just at the bottom of an upward curve? Arthroscopy itself advanced medicine and surgery. It was an innovation. We learned more about anatomy, pathology, and it became very cost-effective. And importantly, it was a precursor to other innovation: minimal invasive surgery, outpatient surgery, surgery centers, and robotic surgery. I want to introduce you to the School of Innovation, maybe matriculation and enrollment, but my purpose here is to engage you in the spirit of innovation, each one of you. I'd like to share the many lessons I learned. My matriculation into the School of Innovation was to improve my skills as a surgeon. At medical conferences in the late 1960s, I learned from prominent sports medicine doctors of the day. They were 100% correct in confirming their preoperative diagnosis at surgery. I wasn't that good. They weren't either. So I published this paper on how bad I was. Innovation is kick-started by a single observation. I like to say, a series of one is better than a series of none. You may see something you never saw before. For instance, I saw spontaneous healing of partial thickness cartilage lesions. A series of one is better than a series of none. There is a curriculum in the School of Innovation. It's a result of a series of many valuable lessons. They're not in the books yet. Timing is very crucial. First, the seed is planted. It takes a long time for germination, and eventually you'll have harvesting. Let's look at arthroscopic surgery. The first arthroscopic meniscectomy was done 95 years ago. Then multiple other people advanced it, and it came to the 1970s when O'Connor and Metcalf introduced arthroscopic surgery. We were off and running. The pioneers that introduced arthroscopy were mainly outside of academia. Diagnostic arthroscopy was introduced by Bob Jackson and Ward Cassells, but then we came to surgical meniscectomy with Richard O'Connor and Robert Metcalf introducing it by mechanical means. Having seen the mechanical way of doing this, birthed the motorized instrumentation. What you must know is that others had the similar ideas or even added to such. Having made a site visit to learn from Robert Metcalf, that birthed the idea of a dedicated facility that would be an arthroscopic suite, a dedicated team, and a visitor suite in order to exchange ideas and show the principles of arthroscopic surgery. The beginning is not the end. Often your critics will not be able to see beyond the beginning, as they did with Ford and said he had a quadricycle. How could that ever be the car of today? Or the Wright brothers, how could that be aviation of today? You can be too early. You can be ahead of your time. What you did may never happen. For instance, I did electronic medical records in 1980. I had more than 4,000 cases. That's 41 years ago. Way ahead of my time. Then in 1990, I did 1,000 consecutive cases. That's 31 years ago. For pain tolerance, not just how much pain, but the person's pain tolerance. That went nowhere. Your first edition of innovation, I like to look at it this way. I like to tell people it'll be this way or some way like this. For instance, I did a shoulder stabilization in 1982 with metal staples. Well, it's going to be this way or some way like it. Well, it happened. By now in 2021, it's done with suture anchors and sutures. What's ironic is the group of specialists most against arthroscopic surgery in the early days were the sports medicine doctors of that day. You might wonder, what is the prospectus of your idea? Well, if the experts of the day are against it, you're likely onto something. You're going to get a lot of stupid arguments, so get used to it, but don't even counter them. For instance, why would you look through a keyhole arthroscopically when you could open the door? You better expect rejection and don't be surprised by it. For instance, the doctors in my town told me I was doing an immoral and unethical operation. If that's so, it's the most common one today. I was banned from Michigan Orthopedics for 11 years. I was blackballed by the Sports Medicine Society. But I think I was in good company. Harrington took 15 years to get his article published in the Journal of Bone and Joint Surgery. And to my knowledge, Burkhart has never gotten one published. Even if they build a monument, you expect more of the same. You're going to be stabbed in the back, but it only happens if you're out in front. You counter with documentation and many convincing proofs. Review the literature, good medical records, visual evidence, be transparent, reasonable conclusions, hopefully a publication. Maybe you'll get a patent. We learned a lot about anatomy by arthroscopy. For instance, in the shoulder, it was thought that all glenohumeral ligaments were the same size and transverse in orientation. By arthroscopy with an inside-out view, we learned they all had different sizes and were oblique in orientation. We gained a lot of pathological understanding by arthroscopy. There was the misunderstanding that the blood supply was deep to the bone. Pretty procedure made many big drill holes in order to access the blood supply. The microfracture was built on the same principle as the Pretty procedure. Arthroscopy provided an opportunity to see where the blood supply was, right at the surface. There was pathological confirmation by gross and histological examination. Arthroscopy provided an opportunity to see the natural history of a sclerotic lesion. In this case, there was spontaneous bleeding seen from the sclerotic surface. It was known for sure that articular cartilage could not repair. Articular cartilage cannot repair. Any repair would be fibrocartilage. If it did, fibrocartilage will not endure. For your information, the meniscus is fibrocartilage and native to the joint. Arthroscopy provided an opportunity to learn the natural history of the sclerotic lesion. Spontaneous repair, even at the end stage, is seen, both by gross and histological confirmation. We published on the same. Having made those observations arthroscopically led to a therapy known as arthroscopic abrasion arthroplasty. A superficial abrasion was made of the surface. Following the superficial abrasion, bleeding occurred. Before and after arthroscopic views showed the area that had been debrided resulted in a repair tissue on the surface. The pathological documentation will show that the fibrous tissue repair endures, seen by gross and histological pathology. We have to have clinical results. X-rays standing at 2 years showed wider joint space in half the patients, and the tissue repair was fibrocartilage. Yet microfracture popularity still exists. There's no coalescence of the surface repair between the holes. Why? Orthopedic surgeons were taught to pound and drill holes into bone. We're repeating what was known for sure. Arthroscopy showed the fundamentals of healing. It's based upon bleeding and clot formation, even like you cut the skin of your hand. So we see wherever surgery was done, a blood clot forms, and it forms the area where we're going to have healing. One thing leads to another. We first started with cortical cancellous grafts, then we did autogenous cancellous grafts adjacent to osteochondritis, and then we did free osteochondral grafts that we showed healed into an articular surface. Documentation and publication are important. Here is a 12 to 21 year follow-up. Let me direct your attention to the slide on the right. This patient had been treated for leukemia, had osteonecrosis medial femoral condyle, huge lesion, grafted with autogenous bone. Here's the 20-year standing follow-up, and on the right we see the range of motion of both right and left knee, which were done similarly. This has been ignored. My opinion is it's unbelievable. Because arthroscopy was very cost effective, it launched bundled payment idea in 1994. When compared to the existing reimbursements, this system provided cost savings when compared to the existing reimbursements. The doctor made more money, the hospital made more money, and the insurer saved thousands of dollars on a 100-patient cohort. It was intended to have the surgeon in control, but no one was interested. Unfortunately, now, bundled payments are controlled by insurers and not doctors. Final lesson: arthroscopy and innovation are paired. We're moving from the unbelievable to the true. You make the observation, you're curious, you question what we're supposed to know for sure, you document, you become a better physician, a problem solver, and maybe you'll matriculate into the school of innovation, moving from the unbelievable to the true. I have never generated an idea, I've only received them. Could the revelations have been providential? A series of one is better than a series of none. Get started. Your innovation will be done this way or some way like it, and remember, one thing leads to another. Please enroll. To think outside the box, you must get outside the box. After you enroll, you'll be moving from the unbelievable to the true. You must get outside the box.